Good morning, class, and welcome to your second podcast on fluid and electrolyte balances. Today we're going to look at fluid volume disturbances, and we'll be going over the principles of hypo and hypervolemia. This is Miss Husson again, and just as a reminder, this podcast is a complement to what you are reading in your book and the other supplements that you have been given. There is a note-taking guide available to you in your N151 packet if that would help you in listening to this information. So let's go and talk about fluid volume disturbances. When we look at fluid volume disturbances, if you'll note on in your book on page 62, this is where the subject begins. And one of the biggest things I want you to remember is that a fluid volume disturbance or hypovolemia occurs when there's loss of fluid in extracellular fluids. This is different than dehydration. Dehydration itself is due to loss of water alone and no electrolyte loss, versus hypovolemia is due to loss of water and electrolytes in the extracellular fluid. Many of the treatments are the same, but it's very important that you understand the difference in that principle. So moving forward, hypovolemia. As we said, extracellular fluid volume loss is greater than fluid volume intake. It's a real imbalance in the system. The pathophysiology of this is basically the tank is low. There is a loss of body fluids. It can occur rapidly with decreased fluid intake. Causes of abnormal fluid loss would be vomiting and diarrhea, GI suctioning, excessive sweating, decreased fluid intake, no access to fluid can occur, and third spacing or a fluid shift when there is movement of fluid from the vascular system to other body systems. That occurs in burns or in another circumstance of ascites, when the liver function is poor and the fluid escapes into the abdominal area. So again, the causes being abnormal fluid loss, decreased fluid intake, and third spacing of fluids. So what are our clinical findings going to be? There is a very important separation in the book and for you to understand of mild, moderate, and severe degrees of fluid loss. Each of these has a major impact on the overall health of your patient. Clinical manifestations generally include weight loss, decrease in skin turgor, as you can see in the pictures, oliguria, which again is decreased urine output of less than 400 milliliters per day, a concentrated urine with high specific gravity, postural hypotension, a weak, rapid pulse, flattened neck veins, decreased in central venous pressure, or the pressure going in the veins that go back to the heart, cool and clammy skin, a smaller tongue with additional furrows, which you can see in that picture, and it really shows how the mucous membranes are dried up within the tongue. Decreased or delayed capillary refill, an altered sensorium, so a change in level of consciousness, and definitely thirst. Diagnostic tests for this particular category would be BUN and creatinine. The volume depleted patient will have a BUN creatinine ratio that is abnormal or greater than 20:1. BUN may be elevated. The hematocrit will be increased because there's a concentration, and serum electrolyte differences will be hypokalemia if it's due to a GI loss or renal loss, hyperkalemia if it's due to an adrenal insufficiency. Hyponatremia occurs with increased thirst and ADH release. And hypernatremia would occur along with this when there's an insensible loss in a situation like diabetes insipidus. When we look at this gentleman here, you can see it's just a summation of the signs and symptoms that we discussed. So what is the medical management for fluid volume disturbance hypovolemia? First, you have to look at the patient needs and the other influential factors. Truly, you have to treat the source, and you have to understand the source. So when we went back to the previous slide and it talked about whether it was from GI or bleeding or other fluid losses, you want to look to the source in your treatment. PO is the best way to replace fluids, although at times with severe we can't do it that way, but we know that the best absorption occurs when PO intake occurs. We also replace with isotonic solutions. So 0.9% normal saline or lactated ringers are the most common, and they're used to treat hypotension due to the hypovolemia because they help to expand the plasma volume. Once a person improves to the point that their blood pressure is normalized, we move from an isotonic to a hypotonic solution and provide water and electrolytes for renal excretion. If the patient is not excreting enough urine, they may become oliguric, and at times they will do a fluid challenge. Fluid challenge is when they give a specific amount of fluid to see what exactly the response of the kidneys are. And we will go over that a little bit more in class regarding the specifications, because you can't give too much too fast. The other thing is when you're replacing fluids, you want to really watch that you don't replace them too quickly. You don't want to go from a hypovolemic state and all of a sudden with a patient that has a compromised system, put them into a hypervolemic state. The way what we monitor that our patient is getting better is a return to normal kidney function with increased urine output. The blood pressure would be better, and the central venous pressure would be better. So when we look at nursing management, I'm hoping you're saying the first thing you'd want to do and the most important would be our assessment. Assessment, assessment, assessment. The only way you know if your patient is responding to treatments and to interventions is to reassess their status. Strict I&O, urine appearance and specific gravity. You should be looking at daily weights, vital signs obviously, skin turgor and tongue turgor, mental function, peripheral pulses, and skin are part of your nursing assessment. Once again, treatment orders are usually PO if we can first. Remember, the patient's oral cavity may be irritated, so you want to be sensitive to that, and they may have some nausea along with it. Probably, if you think about it the most, the best thing we can do for our patients is prevent this from happening. So we need to identify those patients that are at risk for developing hypovolemia. And I'd like you, as part of listening to this, is maybe come up with a list of patients that you can just think of that would be at risk for it. Because the last thing we want to do is have the patient go into a thing called hypovolemic shock. That's when basically the tank is really, really empty and the body system goes into a state of shock, which will be covered more in future courses. But it can lead to system shutdown and eventually death if, in fact, it is not treated appropriately. So moving on to the other side of the scale, let's look at hypervolemia. Hypervolemia is an isotonic expansion of extracellular fluid caused by abnormal retention of water and sodium. Pathophysiology, the tank's now ready to burst. That may not sound the most professional ways, but sometimes that's the best way for you all to remember it. Causes would be fluid overload, giving too many fluids, or someone who's retaining them. Decreased function of the homeostatic mechanisms that we went over in the first podcast. Those mechanisms, remember, they are responsible for regulating fluid balance. And if you remember from the podcast where it was a juggling act, if any part of the systems aren't working right, in fact, people can get overloaded because of that. Contributing factors may be cardiac or the heart, renal or hepatic failure, excess amounts of salt intake, and administration of fluids containing sodium in a patients with an impaired regulatory systems. Clinical manifestations. Obviously, weight gain, edema, distended neck veins, crackles in lung fields, increased blood pressure, bounding heart rate and pulse, hot or cool skin, but usually diaphoretic, increased urine output, shortness of breath, sometimes pitting edema, wheezing, and anxiety. The diagnostic testing would be for increased nitrogen levels in the blood, which we call azotemia, which occurs when urine and creatinine are not excreted due to decreased renal function, and it's related to decreased renal perfusion. BUN and hematocrit will actually be decreased. With chronic renal failure, your serum osmolality and your sodium levels will be decreased due to the excessive retention of water by the kidneys or their poor functioning. A chest x-ray would show pulmonary congestion. Medical management, once again, look at your patient first and other factors that are contributing. Treat the underlying causes. Pharmacological therapy include diuretics. They're usually prescribed when dietary salt alone is insufficient to reduce fluid excess or restrictions of dietary salt, The choice of diuretic depends on the severity of the hypervolemia, the patient's kidney function, and the potency of the diuretic. Some of the diuretics are the thiazide diuretics, such as hydrochlorothiazide or metazolone. They block sodium reabsorption in the distal tubules of the kidneys, and they're prescribed for mild to moderate hypervolemia. Loop diuretics, like Lasix and Bumex, they cause a greater loss in sodium and water, and they block sodium reabsorption in the loop of Henle. They are prescribed for severe hypervolemia, but they also will be used cautiously if a patient's potassium level is lowered. Electrolyte imbalances might occur for diuretic use, and this is very important in your assessment, which we'll get to next. Hypokalemia is common when using the loop diuretics. You need to have potassium supplementation, but must monitor for then hyperkalemia. Sometimes if fluid volume deficit or overload is too much, they will do hemodialysis. If the renal function is impaired, the hemodialysis or peritoneal dialysis actually helps to get the fluid and electrolytes into a balanced state in the extracellular fluid. Nutritional therapy would be to restrict sodium is the most common, and it's based on the patient's needs. Patient teaching is essential. Also know that some communities actually have salt in their water, and they must assess that in a well. Nursing management, once again, first thing we do is assess our patient. You want to assess frequently as well and use critical thinking. Strict I&O, a respiratory assessment for breath sounds, daily weights, vital signs, including orthostatic hypotension for sudden changes in fluid volume, especially when you're treating the hypervolemia. and you need to degree the dependent or pitting edema. Edema is associated with a minimum of 2.5 liters in the interstitial spaces. Pitting edema is associated with a weight gain of 4.5 liters. Treatments, basically as ordered, specify and cause of the hypervolemia, sodium and fluid restrictions, semi-Fowler's and high Fowler's position for lung expansion, patient teaching, which is key, and monitor for signs and symptoms of electrolyte imbalance. Prevention, again, goes back to that very big thing of patient teaching and being aware of those patients that are at risk for developing this. So here's a question for you. Is the following statement true or false? A patient who is experiencing hypovolemia is likely to have a weak, rapid pulse and hypotension. What do you think? Hopefully you said true. Remember, hypovolemia is the tank is low, so you have a weak, rapid pulse, delayed capillary refill, and hypotension. This is the end of the second podcast, and there will be another one on electrolyte imbalances. Thank you for listening, and I hope that this aided in your learning.